Good morning and good day, everyone. Welcome to the conference on the Strengthening Health and Social Protection System in Asia, Challenges and Policy. This conference is the annual conference co-hosted by Asian Development Bank Institute and the Faculty of Economics, Chulalongkorn University. So, as we all know that the COVID-19 has been the severe impact in the past 2 years. It is also the wake-up call for all the government and international organizations to strengthening their health and the social protection system in Asia. And that is why we have highlighted this important to organize this conference moving forward to the policy in the post-pandemic. Joining us today will be both the distinguished speaker from international organization as well as from the university and the think tanks. To start the conference, allow me just to introduce the Dean and the CEO of the Asian Development Bank Institute, Professor Dr. Tetsushi Sonobe, to be the first one who welcome everyone with his opening remarks. Dean Sonobe, the floor is yours.
Thank you, Pichaya. So, Dean Stidat, distinguished speakers and participants, good afternoon. On behalf of ADBI, I'd like to welcome you all to the virtual conference on this strengthening health and social protection systems in Asia, challenges and policies. First of all, I'd like to express my gratitude to Dean Stidat of the Faculty of Economics, Chulalongkorn University, and his faculty team members, Professor Danpong and others, for their continuous support in co-organizing this annual conference. I'm delighted to see a growing and tightening collaboration between ADBI and Chulalongkorn University in providing the knowledge platform for fostering sustainable development priorities in Asia through academic and policy exchanges. I look forward to strengthening further our collaboration in research and capacity building programs in the future. On this occasion, I also would like to welcome and extend special thanks to Professor Nidia Menon of Brandeis University for her special talk on the important topic of building comprehensive framework for health and social protection systems in the post-pandemic. It would be interesting to hear her insights on how to create inclusive systems and mechanisms to protect vulnerable groups in the preparation for crises in the future. I would also like to pass my warm welcome to all distinguished speakers for their participation. I look forward to listening to key insights, fruitful discussions, and the possible policy solutions from the speakers and the panelists in the upcoming 3 sessions. In the past 2 years, COVID-19 has taken millions of lives and created a wider spread of economic and social impacts. Although the pandemic has posted urgent calls for significant progress in increasing social protection measures and universal health coverage all over the world, the barriers to accessing healthcare remain in the form of quality of healthcare services and the range of medical expenses. To give a scale of the problem, financing gap for building social protection floor has widened by 30% since the onset of the pandemic. This is due to the increased need for healthcare services, income security measures, and the reductions in GDP caused by the lack of public health emergency preparation. In Asia and the Pacific, more than half of the population still lacks access to social protection benefits. while public spending on social protection in the region is also significantly below the global average. Following job and income losses, most vulnerable groups such as the poor, women, children, and rural communities are at risk of further increases in poverty. Therefore, we urgently need to accelerate investments in national health and social protection systems, improve access to healthcare for all groups of people, and restore and ensure core healthcare facilities and capacities. Developing bankable infrastructure projects for health sector to put in private finance and strengthen public-private partnership can help to stimulate these investments. To achieve these goals, several vital keys must be emphasized for policy solutions in preparation for a future pandemic in developing Asia. First, mobilizing public and private finance towards strengthening health and social protection systems. Second, fiscal reforms will help to create fiscal space to develop comprehensive frameworks for health and social protection systems. Third, establishing platforms that bring together governments, international and regional organizations, civil society, and academics to support universal access to social protection for individuals, communities, and nations. It's very important to make sure that no one gets left behind. On my final note, I hope that by joining this conference, you will gain practical knowledge and insights for innovative solutions and endeavors that will benefit your country's policy development and design of the health and social protection system. Together, we can enhance dialogue and partnership among us and help shape a better path toward inclusive healthcare schemes and resilient social protection. I wish once again to encourage all participants to actively engage in our discussions, share your experience, and not hesitate to ask questions. Your active participation will make this conference interactive and more fruitful for everyone. Thank you very much, and I wish you a fruitful and energetic exchange of your opinions and great discussions in the next hours. Thank you very much.
Thank you very much, Dean Sonobe, for your opening remark and welcoming everyone to the conference. I also like just to give the floor to our co-organizer, represented by the Associate Professor Sithidet Pongkit Warasin, the Dean of the Faculty of Economics, Chulalongkorn University. Dean Sithidet, I give the floor for you to opening remarks.
Thank you, Dr. Pichia. Good afternoon, Dean Sonobe, Dean and CEO of Asian Development Bank Institute, speakers and panelists, and all participants joining the conference today. On behalf of the Faculty of Economics, Chulalongkorn University, we would like to warmly welcome all of you to this virtual conference on strengthening health and social protection system in Asia. This conference, like Dean Sonobe already mentioned, this conference is an event that ADBI and Faculty of Economics, Chulalongkorn University arrange jointly every year. We hope that this collaboration will enhance the knowledge and discussion among academia and policymakers in the international level in the relevant topics. We would like to say thank you very much to ADBI for our continued collaboration on this. And I believe that our collaboration is very valuable and benefits to our societies. The topic this year related to health and social protection system, which we believe that this is a very important topic nowadays, especially after pandemic eras. This is to enhance people well-being around the world, especially for Asian countries which are very diversified in terms of economic development and social structure. So that makes the topic is really challenging and interesting and very valuable right now. I hope that this conference will serve as a good platform for everyone to share and discuss your idea. I would like to say thank you for your interest and participation. And lastly, I would like to say big thank you to the organization team, especially Dr. Pitya, Dr. Danupon, and other team's members. Thank you very much, and I hope that we will have a very fruitful conference for the half of the day that we have. Thank you, Krab.
Thank you very much, Dr. Sithidet, for your opening remarks. Before we come into the first section today, allow me just to give a housekeeping rule to everyone first. So by attending this conference, it means that you give the consent to ADBI, your permission to use both your name and also your likeness, your voice spoken or written comments, as well as the paper presentation in the available form in all media publication and video sharing website to ADBI without any compensation. Next, please. Also, for the speaker, we kindly request you to turn off your video and mute your microphone when it's not your section. If you have any question or comment, you can type in the chat box, as well as if we kindly ask you to answer the question directly to the Q&A box. Next, please. For the attendees, your audio and video will remain off. However, you had the opportunity to put your question or comment in the Q&A window. Next, please. We also provided the bilingual and the simultaneous translation for this conference in Russian. So by clicking the interpretation that look like the globe sign on the bottom, you can select the language that you would like to listen, English and Russian. Next, please. So here is the agenda for today. We already done with the welcoming remarks. The next section will be the special talk on building comprehensive framework for health and social protection system in the post-pandemic, followed by section 1 on the strengthening health system in Asia, section 2 promoting inclusive social welfare and social protection system for all. And then we will have 5-minute break and come back to the panel discussion on the topic of building resilient health and social protection system in Asia, challenges and policy, which in line with our conference theme for this year. So with no further ado, allow me just to bring you to the first section on the special talk of building comprehensive framework on the health and social protection in the post-pandemic recovery. The speaker who delivered a special talk today is Professor Nithida Menon. She is a professor of Economic Department of Economics, Bangladesh University. Dr. Nithida is a development economist by training. She has worked on the topic that include labor and occupational choice, gender differentiated impact of policy, land rights, conflict, gender specific technology use, in environmental influence on child health, and most recently, adult health in developing countries. Her research includes both theoretical and empirical works and span country in many regions around the world, including Asia, Latin America, and Africa. So today, due to the time difference, she cannot join us, but she have the video messages on her special talks. Please join us and listen to her special talk for today.
Hello, everyone. Thank you for this opportunity to share some of my thoughts on building a comprehensive framework for health and social protection systems in this post-pandemic phase. I'm very happy to get this chance, and many thanks again to the organizers for the invitation. Just to guide thinking on this topic, Given its importance, I've prepared a few slides that I would like to share with you. So why don't we get started? So here we are thinking about a framework for health and social protection systems in the recovery. So if we first begin by thinking about who is it that bore the highest costs of the pandemic in Asia, the bottom line is that it was not just one group. It was, in fact, the group that was most vulnerable, or the groups that were the most vulnerable even before the pandemic. So if we cut this in terms of occupation, you will see that these were informal sectors and essential care workers, healthcare in particular. If you look at it by life cycle wise and by status, these were children and adolescents. The elderly, of course, were at the forefront of this. Women in particular have been sort of distinguished by bearing this double burden of trying to stay engaged in the markets, right, in the working labor markets, but at the same time also having to deal with the additional burden of childcare. And recent research has sort of noted the double burden as well that was being borne by people who have various levels of disabilities. Okay, now even in terms of location and legal status, there's a large group. So both urban and rural areas were vulnerable. Urban areas because of the stringency of the lockdowns, and vulnerable areas because of their insecure income streams. In this basket is included migrants and refugees and asylum seekers. So from this first slide, what you should sort of take away is that when we think about the targets, right, in this post-pandemic, in the recovery phase, the need is to sort of extend better health and social protection systems to many, many groups of people, okay, that are along this wide spectrum of need. Okay, I'd like to begin by sort of highlighting signposts for our thinking on what constitutes important ingredients here, okay? Without a doubt, right, there's no question that access to affordable and quality healthcare is going to be especially important here. So even before the pandemic, a large and significant proportion of Asian households spent more than 10% of their income on health. And we think of 10% as a threshold that sort of demarcates what constitutes catastrophic expenditures, okay? So a large proportion of Asian households are already on the brink. And the main reason for this is a lack of universal health coverage. That was noted as early as 2020. So this is the early months of 2020. Changing our focus to social protection schemes, what economists have sort of tried to think hard about is that we want to try and boost domestic aggregate demand, right, at a time when international aggregate demand is sort of soaking up. And the best way to sort of do this would be to think about social protection floors, which was an idea that it's not new. So the International Labour Office has sort of floated this as a possibility going back almost a decade. And the great advantage of these social protection floors is that, of course, they sort of protect the vulnerable, but they also have these positive spillovers on other sections of the population that are not always in the limelight, okay? So these kinds of social protection schemes are sort of rectifying the structural underlying determinants of poverty and inequality, which, if anything, has been shown to be in sharper relief as a consequence of the pandemic. I want to share two figures with you, which are from ILO sources going back to the early part of the pandemic. So figure one is sort of looking at where were our resources being most concentrated in terms of the type of adjustments that were happening. And what you should see from the left-hand side figure is that over 50%, so over half of our resources were being towards new programs and to new benefits. And then the second largest part was being spent towards program adjustments. So these were things that were already on the ground, that we were sort of building from that infrastructure to try and understand how can we extend support for a larger swath of people. Okay, and just in terms of distributions, which is figure two, a huge amount primarily was going towards special allowances and grants. Next was income and job protection. Unemployment was number 4. Health, which is key, which I would argue is key, was number 6. And then food and nutrition, pensions, children and family, sickness, etc., was a lower distribution, right, in terms of overall shares in the early days. Now that we have some lampposts to sort of guide this, here are some examples specific to countries. So looking first at the health sector, the People's Republic of China, Japan, Republic of Korea, Indonesia, etc., were all at the forefront, sort of providing additional finances for equipment purchases and incentivizing medical workers. That's on the supply side. If you think about sort of on the demand side, right? In India, for example, we under the framework of our public health insurance scheme, which is Ayushman Bharat, we were sort of at the forefront of reimbursing testing in private labs for many millions who were under the scheme. In Thailand, was extending coverage for both nationals and foreign residents to get treatment at any hospital that was closest to them. And then Malaysia, the People's Republic of China, and Thailand was sort of extending benefits to refugees and asylum seekers and to have free access to treatment. Okay, so that's on the health front. Here are some examples in terms of the social protection schemes, focusing primarily on unemployment. You have Malaysia and Thailand that's at the forefront of using their existing frameworks. And then you have other countries, primarily Vietnam, Thailand, and the People's Republic of China, sort of trying to modify existing frameworks to increase, right, the number of beneficiaries. Other countries were working on job retention schemes. And then when we think about providing income security in terms of sickness benefits, Singapore, right, was the country that comes first to mind. A little bit more in terms of social protection, there were modifications to social security contributions, so reducing or waiving contributions. Withdrawals were being allowed from provident funds, which you think of as mainly savings funds by India, Malaysia, Fiji. This emphasis in particular on non-contributory schemes, which are impacting the most vulnerable. So this would be children, those with disabilities, the old age, and then, looking at conditional cash transfers, right? These tried and tested schemes that development economists in particular, have sort of emphasized in these kinds of situations, which are providing support for poor households. Cambodia, Indonesia, Malaysia, Pakistan, and Philippines are some of the examples that come to mind. Okay. To sort of highlight the informal sector here, there were these one-off transfers that were being given. So Uttar Pradesh, which is one of the largest states in India, was doing this for street vendors, for rickshaw pullers. Let me just highlight a few from here. Thailand was providing a scheme for informal workers. Vietnam had this one-off benefit that was being provided for informal sector workers. And then there are many others, right, that were sort of knew what to do and were quick to provide relief. Okay, so Hong Kong, People's Republic of China, Japan, and Singapore. Okay, so far we have sort of understood who are the most vulnerable. What are the key sort of things that we want to see in these support programs in the pre-pandemic stage? What are some examples of things that worked well? Who are some of the countries that were doing that? What I'd like to now highlight, just with the view of sort of guiding our design of these things for the future, is talk a little bit about some of the issues that came up that requires more thinking, and that we want to be careful about in sort of targeting and fine-tuning when it comes to designing these frameworks now, okay, in the post-pandemic phase. So in terms of targeting in particular, we now understand that there is a need to be more inclusive, more lenient, more generous. So some of the ideas that have come up are in terms of having a unified mobile platform where beneficiaries can both access information and opt into options that are available. Strategies that are going to be bottom up, not top down, in terms of targeting and getting relief. And one of the things that has been discussed a lot in the literature is sort of relying more on community organizations and last mile agents in terms of incentivizing them to assist with delivery of relief measures. We really need a public grievance redressal system that is widely accessible, so people can immediately sort of pinpoint things that are not working well, and we can sort of get in there early to correct things to the extent that we can. A more inclusive system of welfare support, so reduce the stringency of poverty tests, right? So worry less about mistargeting, sort of more on perhaps getting relief to people who are, not exactly on the poverty line, maybe a little bit above, but worry more about sort of getting in as many people into the beneficiaries list and reduce the stringency of some of these requirements. And also improve our efficiency in terms of response times and in terms of benefits received, okay? So here's 2 or 3 particular examples where we could have done better. So India in particular, the public distribution system's use of our census data, which is, now more than a decade old, resulted in wide-scale mistargeting, right? Because we were using benchmarks that were outdated. And perhaps a better tool might have been things like the NREGA and job cards, which are more recently updated, right? And updated more frequently to give us a better snapshot of who is it that's most vulnerable and who is it that needs most of our help. If we look a little more to the east in the Philippines, the Social Amelioration Program is a fantastic program that gets CCT beneficiaries and has existed for a while. And they were very successful in sort of getting additional help to the beneficiaries that were already in the system. But it sort of left a few things to be desired when the framework was being used to sort of target new families that became eligible, okay, 13 million new families. So the need to sort of be able to scale up our existing frameworks and to do it in an effective fashion is something that was highlighted very clearly. And then the one final thing that I wanted to sort of highlight within this sort of scope of things that we are thinking about is that the level of benefits that were received were in many cases inadequate. So in Sri Lanka, for example, UNICEF has a study that sort of notes that for the average household, the amount of benefits that were received was only 7% of monthly expenditure. This became slightly larger for poorest households, but only because their monthly expenditures are much lower, right, to begin with, right? So we need some thinking on what is it that the families need and households need, right, the adequate level, and then some consistent effort to get there. Okay, so here's some, examples of things that worked well. These are ILO snapshots of successful health and protection systems at work throughout various countries in Asia and the Pacific, talking primarily, or I wanted to show you primarily in terms of health and in job support, especially job support for women with childcare responsibilities. Okay, now, to end, let me highlight a couple of things that, in my view, would be some of the things that we want to be careful about as we think about developing a framework for health and social protection to improve preparedness. Okay, so we are now in the endemic phase of the pandemic. Access in terms of health support schemes to boosters in particular, especially for the most vulnerable, is going to be key. We need social protection systems that are more nimble and more versatile and flexible, that sort of recognizes that recovery in some sectors has been much faster than in the other sectors. So those, for example, who are able to work from home and have been less affected, right, than those who are require sort of face time. And in particular, the manufacturing sector has been successful in some cases, but not others. So we need some additional thinking in terms of gender, right? In particular, so for example, women in the garment sector, for example, have been particularly affected. Location, rural and urban sectors, proportions in the formal and informal. Think particularly would be informal sector is probably at the forefront of where we should be guiding our thinking, and that's probably the most difficult because they're not under any government rules and regulations, and they sort of exist as what I think of as a pressure valve for the formal sector. But these are where large sections of the population exist, and they are the most vulnerable. Okay. The second or the third thing on the slide is this need for adequate financing, right? So even before the pandemic, so this is studies going back to 2019, the cost of a basic universal social protection package would have been only 1.5% of GDP in Southeast Asia and slightly higher in terms of South Asia. If we sort of move the lens forward to the current time and to the next foreseeable years, right, in terms of the future, the proportions are somewhat higher, but they're still relatively low, okay, and manageable. So I would like to direct your attention to figure 6 on the left-hand side. Let me pinpoint this. Let me pinpoint the red line, which is the cost in selected countries, and this is the Asia and the Pacific for 2024. So this is our immediate future in terms of financing an adequate social protection flow. That's about 4% of GDP. If we sort of fast forward to 6 years in the future, to 2013, that's about 6% of GDP. These are not trivial, I agree, but these are also not humongously large proportions of GDP when we consider other things and in some sense sort of understand that pandemics might not be a once in 100-year phenomenon, and these are not going to be something that we should be thinking about sort of seeing these again, at least if not in our generation of this nature and this scale, at least if not in our generation, but certainly in the generation of our children, right? And figure 7 is sort of a deep dive into the figure 6 numbers, sort of saying that there is a cost that the government will need to bear, and to some extent it's going to peak, right, from 2024 to 2027, 28, and then there's going to be a decline. But in overall, this is going to provide some kind of insurance. So I've already mentioned social protection flows. Let me just sort of say that these are not new targets. So especially in terms of healthcare, so target 1.3 in terms of ending poverty and target 3.8 in terms of universal health coverage are already part of our sustainable development goals. The emphasis is in particular is going to be on non-contributory schemes that are being targeted to those who are not in the workforce to begin with, especially vulnerable in terms of cash benefits for the short term, whether it's wage subsidies or training and job placement. And in recent times, there's been this discussion that we need this process to be participatory, okay? So we need this to be sort of a dialogue between employers and workers, including those in the informal economy, to sort of understand how can we address everyone's needs to the best extent possible. And the final thing I want to say here is this has been a difficult time. And we are sort of thinking about, what we should do in terms of preparedness for the future. But I also want to highlight that there are new opportunities here that we did not have before, okay? And new opportunities in particular in terms of clean energy sectors, which is a discussion that is coming up. And is sort of resonating a lot with the current times. So what we see pretty clearly is that the pandemic has resulted in a temporary shift away from polluting sectors, so in manufacturing and transportation in particular. And so there is an opportunity here to sort of rebuild, but build in a smarter fashion, perhaps in terms of having a carbon tax package for labor market policies especially when we think about reskilling of labor, that could make regions like South Asia, which has been, I say here, one of the highest carbon dioxide emitters, but overall, one of the largest in terms of overall polluting cities in the world, right? So we have some work sort of showing that in recent years, among the 16 most polluted cities in the world, 13 are in South Asia. We have a real opportunity here to sort of direct resources that would result in these countries sort of becoming more productive and being able to contribute additional fiscal revenues, as the IMF notes in a recent publication. But overall, in terms of just increasing the longevity, okay, of their population in terms of health parameters, just by reducing whether it's PM 2.5 or whether it's sulfur dioxide and nitrogen dioxide, right? So there's an opportunity here. And I think it's sort of important to highlight that in this overall discussion about how do we prepare for the future and how can we sort of take advantage of what we all have access to currently. So I will stop there and say I will best wishes for. I will stop there and say thank you again for this opportunity to be here and to share some of my insights and to share some of the research that we all are sort of contributing to. Best wishes for a successful conference, and goodbye.
So that's the video messages from Dr. Nithya Menon from the University of Brandeis University. So the first section that going to happen next is session 1 that focus on strengthening health system in Asia. We have an honor just to welcome our colleague from Chulalongkorn University, Associate Professor Dr. Chantal Herberhaus. She the faculty of she worked with the faculty of Economic Chulalongkorn University in Bangkok, and since October 2017, she has served as a director of the Center of Excellence for Health Economics. So her research interests are in the area of healthcare, financing, and household decision making. Dr. Chantal, I give the floor to you to start section 1.
Thank you very much, Dr. Pichaya, for the kind introduction. And I would like to welcome everyone to this first session on strengthening health systems in Asia. So in this session, we are going to take a deep dive into COVID-19 related challenges and opportunities for the development of resilient and inclusive health systems. So that is health systems in Asia that can cover all groups of people, especially the most vulnerable ones. Now, during the COVID-19 pandemic, we have seen the emergence of many innovations. So some of these could be maintained to make health systems stronger. This would allow health systems to better cope with challenges of aging societies, the growing burden of chronic diseases, and to prepare better for future public health emergencies. The first of today's 2 talks will deal with the potential of digitalization and technology, whereas the second talk is going to look at Thailand's experiences and best practices. The first talk is going to be delivered by Dr. Eduardo Banson, or better known as Dr. Dodo, if I may. He is a principal health specialist in the Southeast Asia Regional Department of the ADB. He's also an honorary visiting associate professor at the National University of Singapore. Before he joined the ADB in 2014, he was, among other positions, he held the position of president and CEO of the Philippine Health Insurance Corporation. The second speaker today is Dr. Siripen Supaganganti, who is an economics professor here at the Faculty of Economics at Chulalongkorn University. She used to be a former director of the Center of Excellence for Health Economics, and she also held the position as chairperson of the Asia Network for Health System Strengthening. So Dr. Siripen has published widely, and she has undertaken consultancy work in over 30 countries. Now, the format of today's session is such that each presenter will have about 12 minutes time for the presentation. And after that, we have about 10 minutes for the Q&A. And all the participants are invited to leave their questions and comments in the Q&A box. I will go through these. Please also make sure that I can see who actually posted the question or the comment, and then I will forward these to the speakers. So that's it about the format for this session. So let me now hand over to Dr. Dodo. The floor is yours. Thank you.
Okay, sorry. Thanks a lot, Chantal. Okay. So I'll be talking about central strengthening health systems in Asia and the Pacific, in particular building on what we have seen with the pandemic. And I think one of the points that we would like to emphasize, of course, is that unless there's going to be a new variant that's going to come out from somewhere from in this world, we're basically seeing signs that the pandemic is being controlled or is about to end. And so the focus more of my presentation is what we need to do now to build a resilient and sustainable recovery from the pandemic. And there was recent work that was done by ADB, where basically there were 5 interventions that were identified to be quite very critical, very helpful in building a resilient recovery. And one of the interventions was basically a recommendation that we need to fortify our health systems with increased investments in health. The other, of course, was addressing our fiscal interventions, was advised to strengthen regional cooperation and to help small enterprise. But let's focus on the recommendation on fortifying health systems. And what we found out is that if we actually increase investments in health, it will actually lead to growth in GDP. So when we look at Southeast Asian countries, and basically if we actually increase health spending to about 5% of GDP, it can actually, across the board, it can actually increase GDP growth by about 1.5 percentage points. And this growth in the economy was coming not just from increased healthcare coverage, it actually would lead, of course, to reduce disease burden and increase workers' productivity and higher labor participation force. So in a sense, although this is something that anecdotally we have always been arguing that more money in health would lead to better economic growth. Now, we actually have the numbers that actually showing that this in this post-pandemic, the post-pandemic world that we're going to enter, that we are entering, there's really need to invest in health. Now, of course, you start asking where shall we get this financing from, more money from health. And what we have seen even prior to the pandemic and even now and during the pandemic, in Southeast Asia, it actually was a lot of domestic resource mobilization. So budgetary allocations for health in the Southeast Asian countries actually increased across the board. And there are also increasing use in what we call health taxes. So these are products like alcohol, tobacco, sweetened beverages, where basically if it can be argued that increasing their taxes means not just reducing the burden of health, but sort of allocating or softly earmarking these increased revenues to go to health. So we've seen this in the Philippines, partly in Indonesia, also being discussed in other countries. It actually bring in more financing for health. We've also seen how national health insurance system, and I will discuss that later, have actually provided more financing. We have seen how we're making transfers to local government in countries that are decentralized, where basically some of the transfers are specifically allocated or earmarked for health. Then, of course, the harnessing of the private sector financing, whether it's the donations, which we saw a lot during the COVID pandemic, or PPPs. Then finally, countries are being able to leverage external and development partners financing, like this from borrowing from ADB to expand the health sector. So where would they spend it? Well, if we look at the service delivery capacity in Southeast Asia, unfortunately, if we benchmark it with upper middle income countries, which of course the aspiration of the countries of Southeast Asia, a lot of the countries actually still have quite low hospital bed to population ratio, physician, and even nurses and midwife. So obviously, among mobilizing this money, it means you need to do some catch up, where you need to build more hospitals, train more doctors, produce more health workers and nurses. So once you have these absolute numbers increase hospital bed and all that, and we don't have the numbers on other primary care facilities, then you'll be in a better position to really leverage this increased health investment for UHC and better economic growth. So what else are we seeing? And in a sense, we saw this during the pandemic. There's actually a move away now from in a sense, the traditional approach where you put government money on the supply side and simply build hospitals, health facilities, and pay workers. You actually have governments putting up national health insurance, which combine or make get, for example, the formal sector schemes where they usually collect from the employees and the employers, and the schemes for the poor and other vulnerable population, where these are fully subsidized by the government, and basically set up this as national health insurance system. So Ayushman Bharat, as described in India, JKN in Indonesia, PhilHealth, PHIC or in the Philippines, and basically this has allowed more money being put into health. It has also been quite easy in the case of the Philippines to justify the earmarking or the soft earmarking of health taxes to finance the subsidies to get people into this national health insurance scheme. It has also allowed or enabled what we call fiscal autonomy, creating a virtuous cycle where government health facilities, health providers will produce care, they get paid by the government insurance, they produce more care, and the money keeps on going on. And it actually facilitates the use of incentives and sanctions in provider payments, so you could drive efficiency and quality, which is quite difficult if you were paying through salaries or just providing budgetary allocations in the supply side. So we are now seeing this in all over Southeast Asia. And as said, during the pandemic, a lot of the money actually flowed to the system. So Thailand has their UCS scheme, which complemented by the civil servants and the private sector scheme called SSO. The Philippines, of course, what they've done, like Indonesia, is they combined everybody into a single scheme. So JKN, Philippines, Indonesia, Vietnam is more like Thailand, but what they have done is there's a single agency actually running everything. Laos is more like the Philippines and Indonesia, where they're combining everybody into a single scheme. Cambodia is like Thailand, getting the formal sector, just getting them to work together and having a separate scheme. But in a sense, what we're seeing in Southeast Asia is these health purchasers have been able to mobilize money over and above than having the traditional supply side. And during the pandemic, money was actually flowed to here and allowed governments like Thailand, Philippines, and Indonesia engage the private sector, not just in testing, but even in the treatment of COVID-19 cases. And we hope to see, and what we're seeing is the strengthening of this national health insurance schemes or health purchasers. So we're not seeing any country moving back away from this approach. What we're even seeing is expansion of this approach. And of course, as I said, if you have NHI, that will enable private sector engagement, as we have seen in the pandemic. And the stronger this national health insurance or health purchasers become, the more that they could be able to enter into purchasing agreements with the private sector that will be beneficial to the government. There are other things that needs to happen. You need laws, you need private sector capacity and willingness to engage with the government. You need government willing to work with moving this approach, because there's a lot of experience from other countries. But if there's one thing the pandemic did, it actually opened up to the private sector, and not just your usual health sector, private sector, that they can work with governments in the health space. And so hopefully all of this experience that we have seen during the pandemic could lead to more harnessing of private sector financing and private sector service delivery in the coming years. Finally, one of the things that we've seen, everybody talks about this, how during the pandemic, digital tools were used, not just in the health sector. It was actually seen all over, whether we talk about the education sector, well, every sector, where basically because of the need to limit of mobility restrictions or lockdowns or whatever you call it in this country, sectors have to start using digital tools. And we had a study done in ADB, which actually tried to see, okay, if we continue doing this, what would be the economic benefits of investing in these digital tools? And there were a couple of interventions that was looked into. Using data to drive public health intervention. That means you invest in all this capturing data, big data, and all that. And the second is in remote patient monitoring. And in both cases, what we have seen that by 2030, all of them would be beneficial, would have some significant economic benefits estimated by the 2030 in Southeast Asia, it will be roughly about $25 billion. So hopefully this economic argument would drive further investment, and that what we have done in incorporating digital tools in the health sector, which of course was not just the use of the tools, actually changes in policy. Electronic prescriptions was accepted. Doctors were willing to do teleconsultations. In national health insurers were starting to paying for teleconsultations. Would continue on because there is really an economic case for it. Chantal? Thank you.
So thank you very much for this enlightening talk. There were a couple of interesting points there that I'm sure will give rise to a discussion later on, especially talking about private sector engagement and the potential of data-driven technologies. But before we move on to the Q&A, may I now invite Professor Siripen to share with us the experiences and best practices from Thailand. Professor Siripen, please.
Thank you, Chantal, and thank you for Dodo for your presentation and introducing on health system strengthening. I would like to share my presentation. First of all, for the how to strengthen the health system in Asia. I don't know, do you hear the sound echo? The COVID-19 related challenges on the development of the Thai. So, may I just, sorry for this a little bit for the second. In general, for the health policy goals, normally the country, including Thailand, we have that at least address these issues on universal and timely access to sustainable, affordable, and quality health care that advances the health and well-being of the population. So the goals of the UHC in Thailand, of course, first, to ensure all members that can access to healthcare or health services when they need, that include during the pandemic, and to protect financial risks of household due to the illness. Of course, the key features of the National Health Security Office administration include policy design for the benefit package, budgeting, design, and management of the provider payment method. And of course, one of the key is on quality assurance and consumer protection. So what the lesson learned from COVID-19 crisis and its impact on Thailand for the opportunity to strengthening the Thai health system. Sorry, I'm going to, okay. First, for the lesson learned that at least for Thailand is pandemic response reform. I would like to share, if you are interested, on what so-called JEE report, the Joint External Evaluation Report for Thailand, that is in the year 2017. It addressed Thailand's coordination mechanism appears to be very well organized, and it is administratively complex. However, because of the complexity of the Thai health system and the Thai administration structure, can lead to the silo thinking and meeting fatigue among experts who are involved in several committees and working groups. Come to in the year 2019, when we start with the pandemic, the silo thinking still is our problem. So how to manage the health system under the crisis? In Thailand, we established what's so-called the Center for the Administration of the Situation due to the outbreak of the communicable disease like coronavirus or COVID-19. In order to strengthen the public health emergency management system through a collaborative approach that involves all sectors, both public and private sectors are contributing to the research, surveillance, vaccine procurement, risk assessment, epidemiological analysis, and control of emergency events. And we have the issues of a large-scale pandemic beyond the capacity of the system. The case of delayed treatment, because during the pandemic, hospitals are overloaded and might be a source of patient infection. Therefore, the patients who are not infected with COVID-19 have a significant impact during the pandemic. Back to the academic data and policy decision might be different, or it is stuck with the procedure. The legal regulations, government regulations, making it difficult to move, and it is hard to get doctors and nurses to act as lawyers. They are not lawyers. When come to some regulation, they need at least from the government regulation, how can they be able to solve that situation? Academic support for medicine and disease control is required, particularly for emerging new diseases like COVID-19 and the pandemic. Health investment, at least in the past for Thailand, we consider that is doing reasonable well, but they cannot support the situation of emerging diseases, which are fluctuating, uncertain, and enormous. So during the pandemic, comparing to the number of patients with COVID and non-COVID and the health system capacity, I would like to share with you on the issue of the 4 waves of the pandemic. You can see from the slide, the most of the specialists, at least in the health system, with the Ministry of Public Health and with the Faculty of Medicine, they discussed on the first wave. You can see that the first wave actually, by theory, is the first 1 to 3 months of the pandemic and can last up to 9 months. If the outbreak is repeated, and we can see that it's repeated, at least for Thailand, at least 3 repeated. And that if the outbreak is repeated, it will affect, it actually affect people's health and hospital capacity. And the number of patients with infection and death continue. By that time, we think that this is our static healthcare capacity in the short period of time. you cannot raise this line up. And then you would like to flatten this curve. It's very challenging. So for the second wave, that is 2 to 4 months after the onset of the pandemic. For some patients, care must be taken after delaying a doctor's visit earlier and may return to infrastructure services. Come to the third wave. The third wave is 4 to 9 months after the onset of the pandemic, when patients with chronic non-communicable diseases like for the diabetics, high blood, like high blood pressure, and etc. With the patient with chronic non-communicable disease who are staying at home or receiving medication through the mail in the earlier period have returned to the hospital for treatment. Thailand expect for the fourth wave. We have experience for the first, second, and third. The fourth wave is 1 to 3 years after the pandemic, with long-term effects in 3 areas. First, on economic injury, which has a chain effect on mental health, psychic trauma, depression, or suicide, right? And in addition, long-standing crisis services affect the mental health of healthcare workers, because you can see from the first, second, and the third wave, number of cases beyond the capacity of the health system. With this problem, mental health of healthcare workers who can experience fatigue and burnout. Come to the problem challenges. Concept of universal health coverage in Thailand, which consider only Thai people, is a problem for disease control, right? Such as in the case of foreign workers and stateless people at the border. The referral system problem include referral patients from primary care to tertiary care, or from community hospital to general and regional hospitals. The complexity of the structure of the urban health system, right, includes the multi-sectoral collaboration, the referral system, the disease control authorities, and problem with the village health volunteer in the urban areas. You might heard about our village health volunteers working quite well during the pandemic, but that is for the rural area. In rural area, we can utilize the village health volunteers, but we foresee that we will have that problem in the future because we do not have enough number of the voluntary health volunteers. But the village health volunteers in the urban areas is a problem. Impact of the COVID-19 of the health system in the long run, especially the debt burden on the Thai government. You can see that from Thailand, public expenditure as percent of the total health expenditure is approximately 72 in the year 2019. I use the World Data Bank to do this for some slide presentation here, because I would like to share to all of you for some other countries as well. When you look in terms of the life expectancy at birth from the high income country and to the high middle income country and the middle income country versus the health expenditure as a percentage of GDP. You can see that for Thailand right now, life expectancy at birth is about 77.6 years. And we spend total health expenditure around 3.79% of the GDP. Look for Japan, is almost 84, but they spend almost 11%. New Zealand, you can see from the high income country, the Republic of Korea, Japan, New Zealand, Germany, all of them life expectancy at birth is higher than 80 years. But for us, it's approaching to that target. But we spend this amount of the health expenditure as percent of the GDP. From those countries in the high income country, they spend more than 10%. And what's the problem next? For Thailand, you can see that maybe the next session will discuss more on the aging society. Thailand will reach that aging society before the year 2020, right? Then you can see that will be here. But for PRC is 2030, Malaysia is 2050, Indonesia, Mongolia as well is this year 2050. For the epidemiological
Dr. Siripen, may I interrupt for a second? Would you mind wrapping up the presentation within 1 or 2 minutes because we are exceeding the time limit? Thank you.
Yeah, then you can see that this is burden of disease toward the chronic disease. But you can see that even though we come to the chronic disease, with the pandemic warn us that we will back to the double burden of disease. And the impact of demographic and epidemiological factor is to increase in demand for healthcare, expansion of infectious unit, and organization of health services. When I present to you what the problem for Thailand, you can see from this table that I break the private expenditure as percent of the total health expenditure. I use the data from the 2019. This is the group that the private expenditure is greater than 60%. This is between 40 and 60%. And then you can see that less than 40% is Thailand, that we have Fiji, Bhutan, and Maldives. Thailand is private expenditure is just only less than 30%. So the most burden is borne by the Thai government. So this is the remaining challenge, roles of medical and health professional. One is now is a big issue now is debating now on primary health care strengthening reform movement and how to produce quality and committed health professional and supporting their career development, supporting the high-tech health services. The major concern about sustainability of public funding for Thailand, how to sustain economic growth, issue of the population, aging of the population, high cost of new technologies and products, and increased demand for healthcare. And that given the right to increase interest in private financing option. And I would like to share with you a bit on the Asia Pacific Network for Health System Strengthening. This is the framework that we have the workshop and training at least every year. During the COVID-19 pandemic, we do the online course. And next year, we expect to launch this again. So the last slide is on policy suggestion. We think for Thailand is changing from a free market to technology-driven for a sustainability-driven concept and continue accelerating the implementation of laws and regulation defined in the Communicable Disease Act for disease control at domestic and international level, stimulating the full implementation of the IHR for health security policy. Consider supporting both the budget and human resources in terms of amount, technical skill, and quality. Defining duties and job responsibility of all agencies clearly, engaging the private sector of communities as a key stakeholders in preventing, detecting, and responding to all events and disease control. and producing quality and committed health professionals and care workers and supporting their career development. Thank you for your attention.
Thank you very much for this very comprehensive presentation. There were a lot of interesting points there. So first of all, the detailed insights into the key challenging that the Thai health system is facing, especially also its universal coverage scheme. But yet at the same time, the pandemic has actually shown that there are a number of opportunities because we have seen that certain changes were made and these changes can actually be sustained. For instance, if we look at the coverage, the Thai universal coverage scheme covers Thai nationals, but during the pandemic, certain services were also extended to non-nationals. So this is just one example of changes that have taken place that one can look at to basically see whether these could be maintained to enhance the performance of the health system. So with these remarks, again, I would like to extend many thanks to the two speakers. If I could invite Dr. Banson to please also turn on the camera so that we can start the Q&A. I've just checked the Q&A feature. There are no questions in there. So again, if I can invite the audience to please leave comments, messages, suggestions in the Q&A box. I will then take these up and directly ask the speakers. So in the meantime, while you are perhaps thinking, I might take the liberty to ask the first question. That's a very general question. And again, it brings me to the issue of coverage, because one of the things that policymakers need to consider is really how universal should the universal coverage actually be. So typically we're looking at certain defined population groups, target beneficiaries, but we have seen during the COVID-19 pandemic that this issue of coverage really needs to be discussed again. So in Thailand, Dr. Siripen pointed out that there are many migrant groups that are not covered by the UCS. There are other schemes, but yet there seem to be gaps. And also if we look at persons without legal nationality in Thailand, again, they're not covered by the UCS. So these are just examples of gaps perhaps we need to consider. If I could invite both speakers to perhaps share their thoughts on this issue with me. So how universal should the universal coverage scheme be? Thank you very much.
Dodo would like to
Yeah. Sorry, I was just trying to unmute myself. No, and thanks a lot, Chantal, for the question. And I think what we have seen, I think there are a couple of things that there were 2-3 things that partly from the pandemic, even before, that we're seeing, which will probably lead Southeast Asia, and I prefer to limit to Southeast Asia, where you could have coverage beyond borders. Okay, so of course, one, as I showed earlier, there's really now government purchasers that are now being established, or whether it's the National Health Insurance System or Ministry of Health, assuming a government purchasing function. So we're seeing that now in most of the Southeast Asian countries. And that means it will facilitate agreements between purchasers, so that when their citizens move from one country, their nationals, and get care there, then payment can be made. If you don't have those purchasers, it will be difficult to imagine what type of agreement you'll have with Ministry of Health. I don't think their procurement or audit rules would allow that. Second, this is vaccine certificates. So what we've actually seen with vaccine certificates is vaccine certificates in one country can be read by other countries. Okay, so that means it can actually be done. You could actually have your health records, although vaccine coverage, vaccination is very small. You have a proof of concept that if countries sit down and agree with each other, the technical challenges of sharing of data would actually be resolved. And so I think so we should build up on that success that we have, where we're actually getting one country reading their vaccine certification of the other country. And I think third is what the pandemic have shown us, that if countries don't work with each other, countries lose out. So we don't have to talk about how vaccines, how countries in South Asia struggled to get vaccines. And so there's actually a push now among political leaders to talk among themselves. Thailand has always envisioned vaccine self-sufficiency, championed that. Maybe time to sit down and agree with each other. And if you start talking about sharing vaccines, resolving who will manufacture and not manufacture, moving forward with the ASEAN CDC, I think they have a nice name there now, CIPED, Center for Public Health Emergency. The idea of having a common lab talking to each other, for me, these are big steps. And if you move forward with this, then coverage would be something you could sit on the table and gets to resolve. We are aware of the sad experience, how so difficult it is to get mutual recognition agreements among regulatory agencies, among health workers, that ASEAN, that was never resolved. Hopefully, if there was one thing the pandemic could drive, it is finally getting Southeast Asian countries to work together, and coverage beyond borders would become a reality.
Thank you. I would like to share with you that when you talk about all the UHC, for each country, normally in Asia, it just focuses on the citizen of that country or the residents who register with the system. The state, the one that I present on the state list, people or with the foreign workers, but illegally. Not legal, because legally they can access, but illegally. That Thailand, we have that problem. Illegal workers, that is a problem during the pandemic for disease control. And then you can see from the slide that I share, you can see that during the pandemic, you have more number of cases beyond capacity of the supply. That not possible for any country to prepare the supply in order to be able to treat all cases during the pandemic. And then we have to pool all resources at the most that we can pool for the COVID-19 in order to flatten the curve, because we expect perhaps it will be a lot for 1 to 4 months, but because of repeated like the outbreak are repeated in time, were repeated, and that's why we have more cases, right? And then we cannot flatten the curve, and we cannot raise up the health system capacity in the short period of time. Even though in the long run, how much the country be able to have more resources in order to invest more in the health system. And that's why we think that we need to move from technology-driven concepts to the sustainability-driven concepts. And then look at the role of the medical school and other schools who produce a medical doctor, like particularly for primary healthcare strengthening policy, because that is the key in the future, because they are the one who actually work, like at the grassroots, at the baseline, they work with the communities. And most important, that you need to involve the stakeholders, not just only for the public stakeholder, there are private stakeholders, not just only for the private providers, we have for the finance as well, funding sources. You can stimulate and encourage the private to use the private sources, at least during the pandemic. And most important is silo thinking. You see that happened. For example, for Thailand, the Ministry of Health, Ministry of Interior, Ministry of Education, Ministry of Defense, and etc. When they come into the meeting, right? Because that is by the for the Prime Minister office, we set up a new of the committee who govern for all of those. So from that experience that we learn and we share, at least we can work across the ministries quite well during the pandemic. We should continue doing like that. not just design at the organizational level only. Like from that lesson, it should be last, like for us prepare for a new pandemic that we think that we might have. And then the fourth wave coming with the burnout of the health workers, health professionals working in the health system, their mentality problem. That is what we discuss at the moment. Thank you.
Yeah, thank you very much. So unfortunately, we are running out of time. I've already checked the Q&A box. There are no questions from the floor. So I think I can put it in a nutshell that one of the important issues we need to look at is basically increasing collaboration. And that means across private and public sector, across borders, as Dr. Banson shared with us, and then, of course, across organizations. So that's the key. The challenges we are facing are so complex. So that means without collaboration and constant exchange of information, we wouldn't be able to solve these challenges. So I would like to give a big hand and thank you to the two presenters and give the microphone back to Dr. Pichaya. Thank you very much.
Thank you very much, Dr. Chantal, Dr. Dodo, and also Dr. Sripen for the comprehensive insight and also presentation that you shared with us on the section 1. So next, we would like just to move to the section 2 on the promoting inclusive social welfare and social protection system for all. So our moderator is my colleague from ADBI, Dr. Yixing Yao. She is a senior research fellow. And before she joining ADBI, Dr. Yao worked at the Ministry of Finance of the People's Republic of China in the various capacity. Most recently as a director of the Division of Finance and Project Programming Department of the National Economic and Finance Corporation. So Yixing, I give the floor to you to start section 2.
Thank you, Pichaya. Thank you very much. It is my honor to moderate this session. The topic of this session is promoting inclusive social welfare and social protection system for all. We will focus on how to leverage domestic resources and mobilize financial resources to support the development of comprehensive and inclusive social welfare and social protection for all of the people in the society and the economy. The discussion includes strengthening fiscal framework, social protection schemes for vulnerable groups, and international cooperation. We have two distinguished presenters here, and everyone will only run for 12 minutes. We are already ahead of our schedule, so I hope our presenter could focus on the time now. After both presentations, we will have questions and answers. So please feel free to raise questions and put it in the Q&A box. Now, please join me to welcome the first presenter, Dr. Upala Kowatanasaku. Dr. Kowatanasaku has PhD in development economy from the University of Waseda here in Tokyo. And he is currently an associate professor at Waseda University. And most of his research is on various economic, environmental, and social development topics in East and Southeast Asia, such as aging society, climate change, health and social services, information economy, and labor market, and sustainable development. He has worked and had research collaborations with major international organizations and research institutions, such as Asia Development Bank Institute and the Economic Research Institute for Asia and East Asia, ERIA, and special agencies and programs of the United Nations. Dr. Kowatanasaku will talk about policy recommendation for the development of inclusive social protection and pension scheme while maintaining and achieving fiscal sustainability. Now, Dr. Kowatanasaku, please, the floor is yours.
Okay, thank you very much for your kind introduction. So let me share my screen first. Okay. So can you see my screen?
Yeah, thank
Yes.
you.
Okay, thank you very much. So first of all, I would like to thank the organizer, which are ADBI and also Chulalongkorn University, to let me be part of this wonderful program. So I'm really honored to be here today. So just first, I just want to give a little bit of the background or the motivation of this topic. So in 2020, I had an opportunity to work on a paper regarding the demographic transition and its impact on fiscal sustainability in East and Southeast Asia with Dr. Pichia and Mr. Adam Majo from ADBI. And this year, Dr. Pichia kindly invited me again to join the G20 Task Force on Inequality, Human Capital, and Well-being to develop a policy brief on achieving resilient and inclusive social welfare system for aging societies. So actually, today's presentation is the result of the combined research findings and observations from our book chapter published by ADBI and also from our policy brief published by the T20. So first, I would like to give you some of the overview on the current challenges that we have been facing so far. So this table shows the demographic status in East and Southeast Asia in 2020. So if you look at the last column of the table, you can see the status of the demographic status of each country in this region. And you can see that many countries in Asia have already entered or are entering an aging society at different demographic stages. So the phenomenon of rapid population aging is threatening not only economic stability, but also the social security of every nation across the region. So the global outlook of the general government fiscal balance has consistently demonstrated a fiscal deficit. For example, in 2020, taking into account the impacts of COVID-19 on health and economic sectors, the IMF projects overshooting of the fiscal deficit due to its increased spending on health and additional support for people, firms, and also sectors. So if we look at the first diagram, which is from Japan, so Japan's fiscal position has shown a continuous fiscal deficit since 2000, whereas the data show that government health expenditure is relatively high and generally rising over time. So this also happens in other East and Southeast Asian countries, such as Singapore and the Philippines, represented by the middle and the right diagram. So although the increasing trend of health expenditure has been evident in most countries, not all countries allocate a significant amount of their spending on health. According to the World Health Organization or WHO, health expenditure in lower income countries was financed primarily by out-of-pocket spending, whereas government spending dominates high-income economies. So for the past 2 or 3 years during the pandemic, we could see that the COVID-19 pandemic has added threat by heavily affecting the older population. So low immunity, possible comorbidities, and financial vulnerability have put older people into the most at-risk population group among other groups. So regardless of the demographic status among East and Southeast Asia countries, the population aged 65 and above make up the majority of COVID-19 deaths. For instance, if you look at the diagram on the right-hand side, you can see that the diagram shows the situation of COVID-19 death by age in the Philippines and Japan, comparing a young society with a super aged society. However, in both countries, we could see that the aging and aged population made up the most share of COVID-19 death. So in order to deal with this threat, policy solutions are proposed for developing comprehensive social welfare frameworks for aged and aging societies, promoting social protection, and also preventing longevity poverty. So first, a comprehensive review of public health expenditure will help improve the government fiscal balance and achieve fiscal sustainability. So in general, reviews of public health expenditure will help governments address issues related to the distribution of health spending and services across the population. Moreover, such reviews will also improve the efficiency of healthcare provision and help evaluate the macro impacts of revenues and expenditure on society. Second, a healthcare reform is needed to not only strengthen social and economic inclusiveness, but also to maintain buoyant fiscal balance. Given the characteristic of healthcare services, policymakers might find it difficult to strike a balance between promoting equity or equitable and affordable access to a set of basic health and social services and modernizing the health and social services sector with recent technologies. Reforms should be conducted on 3 principles, including accessibility for all universal healthcare, efficiency in healthcare services, and also cost control and monitoring. And the next proposal is about the cost sharing measures. So the cost sharing measures should be considered to reduce the age-related fiscal burden. The cost sharing approach usually involves insurance and pension schemes through individual contributions. In other words, the cost sharing approach requires individuals and healthcare consumers to pay a portion of their healthcare expenses in addition to financial support from the government. And the last proposal from our research is that we should also develop a sustainable pension system that minimizes old age poverty and also equally distributes a financial burden across generations. So if we look at this policy proposal, we could see that the structural reforms for a sustainable government budget and pension system go beyond the reform of a pension system itself. So the reforms cover the broader issues of social equity, such as gender, informal workers, workers with low economic status, and intergenerational poverty, and also financial inclusion, labor force participation, formalization, and other macroeconomic and fiscal factors. Therefore, developing a sustainable pension system that minimizes old age poverty and equally distributes a financial burden across generations must integrate 4 extensive policy areas, including a pension system, a labor market, a financial market, and also key macroeconomic factors. Policymakers must fundamentally address the trinity of challenges present in this figure. So it's on the right-hand side. So in this figure, it shows the trade-offs amongst different areas. So we can see the fiscal and pension sustainability, and also old age inequality and poverty reduction. And the last component is the equal distribution of financial burdens across generations. And this slide just gives you some of the specific policy proposals, like for each elements, but I think because the time is limited, so I would like to skip this. But if you have any questions upon this trinity of pension reform challenges, you can ask me in the section. Okay, so that's conclude my presentation. So thank you very much for your attention. Now you can just click in this slide and then.
Okay.
Sorry. Okay. Yes. Thank you very much.
Okay. Thank you very much. Thank you, Dr. Kowatana Saku, for your insightful and informative presentation. The policy recommendations you share are really valuable for the policymakers. I think the pension reform challenges you mentioned is a crucial way to look at the problem at hand. Now, I would like to invite our second presenter, Dr. Varawait Suwalada. Dr. Suvalada has a PhD in economics from Osaka University, and he is currently a professor at Chulalongkorn University. Before joining Chulalongkorn University, Dr. Suvalada was an assistant professor at the Graduate School of Economics, Osaka University, Japan. And in 2019, he received the National Distinguished Researcher Award in Economics from the National Research Council of Thailand. He also served as the Dean of College of Population Study, and Dean of the Faculty of Economics at Chulalongkorn University. Currently, Dr. Suvalada is also serving as a committee member of the National Elderly Committee, and his main research focuses on old age income support, social protection, and public finance. Dr. Suvalada will talk about how Thailand promotes inclusive social welfare and social protection for all, challenges facing Thailand, and policy recommendations. Now, Dr. Suvalada, please, the floor is yours.
Okay, thank you very much, Dr. Yishin. Good afternoon, everyone. I am Borowet Suvalada from Chulalongkorn University, Thailand. I would like to express my thanks to ADBI and Faculty of Economics, Chulalongkorn University, for allowing me to be here and to give a short talk about promoting inclusive social welfare and social protections for all in Thailand, challenges and policy recommendation. Next slide, please. As you see in this slide, the Thai government has provided various social welfare and social protection systems in order to cope with various contingencies such as sickness, including long-term care services, occupational hazard, disability, old age, survivors, housing, unemployment, children and maternity, and the support for the poor and vulnerable groups. In spite of the fact that Thai society can currently achieve or can approach more inclusive systems for all, for some benefits, such as Professor Philippen mentioned about universal coverage for health security or old age income security, namely approximately 90% of Thai older persons are receiving tax finance pension in forms of government officials pension or old age allowance. However, considerable questions are significantly being brought up in our society at this moment. For instance, should the old age allowance be transformed to the so-called universal basic pension as a social protection floor, or should the amount of old age allowance be increased to from approximately 16 to 27 USD per month to more appropriate higher level? Or how can we extend the old age income security coverage to working population wider, especially for one in informal sector? Or under the situation of fertility decline, should the so-called child allowance be universalized to all families with children or not? Currently, social welfare and social protection systems in Thailand are facing tremendously challenges and hesitantly standing at the crossroads ahead. Due to time limitations, I would like to raise and describe 4 issues very briefly. Next slide, please. The first challenge is that Thailand has been confronting continuously structural issues, namely poverty issues, population aging issues, and the labor market structure. As you see in the slide from the left-hand side, according to the latest official report on poverty and inequality in 2021, in Thailand, there still exists approximately 4.4 million poor population, or about 6.3% of total population. Among them, poverty rate of children and older persons, respectively, are higher than that of working population. Therefore, poverty relief are always positioned in public policies objective with a high priority. At the same time, Thai society has already jumped into the age society. We already have a proportion of population at age of 60 and over on total population, approximately 20% at present. The proportion will apparently increase to 25 and 30% respectively in next 10 and 20 years. Inevitably, the proportion of population at age of 80 and over will be starting to increase in next 10 years. Learning from many age and super age societies experiences, we can expect more exceeding demand on the government policies like pension, health care, long-term care, or social services for older persons. The last structural issue of Thai society, as I mentioned, is the labor market structure. As before, non-employees are still occupied more than half of workers. In other words, we still have a big informal sector. This structure seems to be maintained or probably expand continuously after the expansion of the economy during and after COVID-19. Next slide, please. The second challenge is the so-called disparity among populations' work status under current institutional settings of social welfare and social protection system in Thailand. More or less, this challenge relates directly to the structure of the labor market and the significant size of informal sector in Thailand. Even though Thailand has some good practices on social welfare and social protection systems which can achieve or nearly achieve an inclusive system for all, such as as I mentioned before, universal coverage for health security or nearly universal social pension for older person. However, even such good practices are still criticized because of disparity in many dimensions among populations, such as the adequacy of benefits or source of fund or budget allocation from the government. I will raise the disparity issues in public pension system and health security system in Thailand as examples that reflect this challenge. If you see the picture in the left-hand side, we can confirm the fact that this entire picture of public pension system shown in this slide, although old age income security of Thai population at age 60 plus will be guaranteed nearly universally by tax finance, old age allowance, and government official pensions. However, during working period, only government officials and employees in private sector compulsorily contribute to their relevant contributory schemes, namely government pension fund scheme or social security system scheme, respectively. But unfortunately, working population in the informal sector and the rest are recommended to prepare towards old age voluntarily through social security system special options or the so-called national saving fund. Without any compulsory conditions, many of them may fail to do so, and finally they get only old age allowance without any additional pension from other schemes. which may not be adequate for their old age standard living. For healthcare financing, Professor Siripan has mentioned already that there is also disparity among populations, work status, and systems. While CSMBS is the civil servant medical benefit scheme and universal health security scheme source of fund are nearly 100% government budget or tax finance. But unfortunately, approximately 11 million members of social security system, including me, are forced to pay contribution to the fund every single month to get or enjoy medical service. Of course, budget allocation between the so-called CSMBS and Universal Health Security Scheme are also different. The CSMBS budget style is open-end, while the budget allocation for Universal Health Security Scheme is the closed-end. So we still have a disparity among systems. Next slide, please. The third challenge, as shown in this slide, from the public financing perspective, current social welfare and social protection systems rely mainly on tax finance system. In addition, we must note that local authorities do not contribute much in those systems. Fiscal burden is mostly borne by the central government. If we pick up the big four systems with source of fund is government budget, namely Civil Servants Medical Service Scheme, CSMBS, Universal Health Coverage Scheme, UCS, government official pensions, and old age allowance, which I call big four. In fiscal year 2021, total government expenditure on the four big systems account for 662.4 billion Thai baht, or about 18 billion USD, or approximately 22% of central government expenditure, or it accounts for 4.1% of GDP. Due to the change of the age structure to the age and super age society and high rate of economic growth cannot be expected as in the past, drastic increase in social welfare related government expenditure and sources of fund for achieving inclusive system will be exactly big challenge for Thai society. And I would like you to notice this slide again. This slide has reflected another aspect of current system that we should take into an account. As I mentioned before, many schemes here relied on the tax financing, definitely. You can see that I put red mark after the name of the systems. However, if we focus on some benefits like healthcare, old age, or child benefits, we can confirm the fact that the government is using various finance schemes to provide those benefits, namely tax financing, social insurance, and savings scheme. Professor Philippen used the word silo. Exactly, this slide showed the silo in the social protection system in Thailand. So if the Thai society set social policy objective to realize inclusive social welfare and social protection system for all, how can we consolidate or integrate or say coordinate among those existing schemes? This will be a big challenge for Thai society. For example, if we take the pension schemes as an example, should we position old age allowance as basic pension? If we say so, what is the desirable in Thai pictures of pension system design that includes tax finance pension, old age benefits under social security schemes, and various saving schemes such as the government pension fund, national saving fund, or even provident fund (PVD). If you see child benefits, now we have two systems. The one for the child allowance in low-income family, and another one for the child allowance for the member of Social Security system. If we think that child allowance should be universalized, if so, how should we manage child benefits under the Social Security scheme if we universalize them and use the tax finance as a source of fund? And the next slide, please. And the last challenge that I would like to address here is about the stance of the government to gear this country's social welfare and social protection schemes to more inclusive systems for all. I have a lesson learned from some policy movements on old age allowance system, which more or less reflect the hesitating stance of the government on pushing to the direction of universalization. As I repeatedly mentioned that old age allowance in Thailand is currently nearly universal. The scheme excludes only government official pensions beneficiaries or actively working age of 60 plus government officials and older persons in the government care facility. At the same time, outside the government sector, there are social movement pushed forward by like a civil society, and at the same time, there are movements of the pre-national election campaigns by many political parties to support the positioning of the old age allowance, and they call for changing old age allowance to basic pension or population like a citizen pension, something like that, and increase amount of the benefits from 600 to 1,000 Thai baht to more appropriate level. However, the government was not so responsive to those movements, but launched something like the pro-targeting schemes instead, namely like a old age allowance donation campaign to the senior citizen fund, or the government provide the so-called additional allowance for low-income older person scheme. So there's something like like a conflict between the idea of the government on old age allowance and the social movement, or like a politician side. Of course, behind those decision-making, fiscal authorities, including Budget Bureau or Ministry of Finance, took serious concerns on the fiscal disciplines and fiscal sustainability in the future. And as I mentioned before, poverty relief is still a policy objective of the government with a high priority. So finally, next slide, please. I would like to close my presentation by raising at least 3 policy recommendations for strengthening fiscal framework to support the development, inclusive social welfare and social protection in Thailand. Firstly, Thai society should have something like the national platform mechanism to engage all relevant stakeholders to share common concerns on social welfare and social protection, including like a political view or diversified principles and values, needs of various groups and generations of population, availability of fiscal space under current system at present and the future, or possibility additional sources of fund and political process. Such mechanism is expected to bring about some elements on characteristics of inclusive social welfare and social protection system, which all stakeholders do agree upon. This kind of information is extremely useful for inclusive system design in the future. So I think to learn the experiences from the other countries is an important issue. Secondly, in order to achieve inclusive social welfare and social protection system in terms of coverage and adequacy of benefits, as well as fiscal sustainability simultaneously, at least 2 sources of funds should be taken into an account immediately. The first one is that the government should review VAT rate maintenance at 7% So increase to 10% as scheduled, and its usage as a source of fund for strengthening social protection schemes for all should be taken into an account. Secondly, the contributory scheme should be considered as an alternative source of fund for some types of benefits, such as the old age pension. Both non-contributory scheme and contributory scheme should be taken into an account at the same time. Specifically, for example, if you want to reform old age allowance system, at the same time, you have to make a linkage with another contributory system. For example, National Saving Fund. We should do reform simultaneously, not do something like a silo. Finally, the third recommendations to cope with more forthcoming super age society, which is expected as the main driver of social welfare related government expenditure. The government possibly takes the provision of social services into an account as an option to design inclusive social welfare and social protection system, especially utilization of community services, which is based on communities, social capital. This kind of option may more or less like reduce some costs and increase quality of life of population directly. Thank you. That's all for my presentation. Thank you for your attention.
Thank you very much, Professor. Thank you very much for your impressive presentation. And now we have a Q&A box. There is a question from Joe Chia. His question is talk about when talking about social protection, one big category is a cash assistance or cash support. In many countries, cash assistance have been consolidated from multiple programs and agencies into one prime cash assistant with better quantum. So are there any good cases studies of how country could overcome the challenges of consolidating cash assistance, and how did they do it? We are already run out of time, but I still would like to Professor, please you think of this question and give us a very short answer. Everyone, I don't know where this question to go to which professor. Anyway, two of you, if you like answer, everyone have like 30 minutes, 30 seconds to answer this question. Thank you. Please look at the Q&A box. Thank you, Xiaohua.
Okay, let me answer first. I'm not sure this is a good answer or not, but of course, in case of Thailand, the bureaucracy of social protection system is silo, as Professor Siripen mentioned. We have many programs of cash benefits, and they are under the supervision of different ministries. But in last 3 or 4 years, Ministry of Finance try to consolidate not the system itself, but the information. But the information at the Ministry of Finance to overview who get benefits from which system. Now, if those kind of information system has been implemented or introduced, at least we cannot consolidate our system, but we can see who get what kind of benefit at the same time.
Thank you, Professor. And then Professor Kavatana Sukho.
Yes, for me, I can't really come up with the answer right now because when I look at the policy, I look at the macro level, so I don't really check the details of the how they consolidate like all this like cash assistance. But as Professor Moravec said, like top of my mind now, like I don't really see any countries that pool all the money together and then give like one like social protection like program or like project. So if I found any case studies that I would like to share with Mr. Joshua. later if he could provide us with his email or something. Thank
Okay.
you very much.
Thank you very much to professors. Thank you very much for your very valuable presentation. And it is my pleasure. And even though we have some questions, we can exchange views later. Now, I would like to thanks to my colleague Pichaya. Back our session, we talk about the social welfare and the protection system. So if we have 3 keywords to take away, I would like to say first is inclusive, second is resilient, and the third is reformation. So I hope all of our participants enjoy our session. Thank you. Now the floor is yours, Pichaya. Thank you.
Thank you so much, Yixing, for your excellent moderating skill. And also thank you, Dr. Warowit and Dr. Uparat, for your comprehensive presentation and your insight. So because we are a little bit running out of time and also behind our schedule, allow me just to take a break for 5 minutes before we come back to the last section, which is the panel discussion. So from now, we will take like 5-minute break and come back roughly about 5:08 p.m. Japan time or 3:08 Bangkok time. See you.
Thank you everyone for joining us today and welcome back to the conference. We have now reached to the last sections of today. Dr. Prichya Siriunabut will take a role of moderator for the panel discussion. She is the Deputy Head and Senior Economist of Capacity Building and Training, ADB Institute. Dr. Prichya, the floor is yours.
Thank you very much, Prishaya, and welcome everyone to the last section of this conference. The panel discussion will focus on the building resilient health and social protection system in Asia, which we will discuss about the challenges and policy. We have 4 distinguished panelists joining us today, which will give you the insight at the regional level, the overview, and also the challenges. At the country levels, we have representatives from 3 different economies. So I'd like to welcome the panelists, which the first one is my colleague from ADBI, Dr. Dil Rahat. He's the Vice Chair and the Senior Research Fellow from the Research Department from ADBI. We also welcome Dr. Nopon Witwarapong, which is the faculty member of the Faculty of Economics, Chulalongkorn University. We have Dr. Youngbok Lee, Senior Director from Department of Public Finance and Social Policy from Korean Development Institute. And we have Dr. Ilan Satrivant, who is the Chief of Policy Working Group, National Team of the Acceleration of Poverty Reduction from Indonesia. Dr. Ilan also the co-chair of the T20 Task Force 5 for this year under the Indonesia presidency. So with no further ado, let me just start with the discussion with our vice chair from the ADBI, Dr. Dil Rahat. So Dil, we had heard a lot about social protection, how to do this resilient health system in Asia and the challenges. So in your opinion, what are the challenges brought by the COVID-19 to the development of this resilient health and social protection in Asia?
Thank you, Dr. Pichaya. This is very, very interesting question. As you know, the COVID-19 has been very catastrophic to the global community. It has adversely affected our social, economic, health of individual families and nations. We have lost lives. We have also lost wealth, and we have also lost health. However, if you look at COVID-19 pandemic, it has the impact has been more devastating in developing countries, particularly the vulnerable group, the poor household, the female-headed household, and those working in the informal sectors has been worst hit by COVID, leading to loss of livelihood, increase in poverty, debt, food, nutritional insecurity, and hunger. So this pocket has been very, very severely hit. And if you look at Asia, like the COVID-19 has really exposed us, despite rapid economic progress that we have made in agriculture sectors, in industrial sectors, in financial sectors. The COVID has really exposed weaknesses, particularly in the social protection systems. During this pandemic, we found that large segment of the Asian population, almost half of the Asian populations, do not have social protection coverage. So that's a lot. And if you look at different countries, only a few countries have very comprehensive social protection systems, which is very comprehensive. So many countries do not have a very solid social protection system. This COVID-19 pandemic has highlighted the need for well-functioning social system that we need to put in place as never before. And the social protection system in the region is, I think, I would say that it's heavily underinvested. If you take out like health expenditure, only about 2% of GDP gets into the social protections, as against 11% globally. So which means that we are very, very invested. Therefore, there is a need to build a social protection system that is very comprehensive, very solid, and very inclusive one. However, the major challenge is that we are also facing other disasters, like the climate risks, the food security threat that's being created. So we have competing demand. So it's very difficult for the Asian countries to see how they can allocate their resources in social sectors so that everybody is under the social protection coverage. I think that's one of the major challenges that we are facing. Nevertheless, I think as some of our presenters have highlighted, there's a need for us to come together, work together, and build a system, that is very inclusive, that is resilient, and that's sustainable. And so I would say that, but the challenge is humongous, particularly lack of infrastructures, lack of resources, both financial as well as human resources.
Well, thanks so much, Dil, for the first interaction. So I just want to move to Dr. Nopon a little bit, because Dil has already flagging about the challenges and how would that affect the development of the resilient health and health system. So can you at least give us a little bit of the idea or the concept of the resilient health system, and what do you think of this idea? Do you think it's feasible or applicable, particularly when it's come to Thailand case? Because we have heard from Dr. Siripen and also Boroved about both health system and the financing to the health sector. So in your idea, can you give us just the concept of the resilient health system, and also is it feasible? Thank you.
Okay, thank you, Dr. Pichaya. Allow me to share the screen. So hopefully you can actually see the screen now. I think it's important for us to, first of all, define the term resilience, especially with regard to the health system first, before we basically move forward. And I'll have some answers for you with regard to Thailand later on, if I may. But first of all, allow me to define some key concepts first. So when you talk about a resilient health system, I think there are basically two terms that we need to define. The first one is the term health system. So health system in and of itself needs to be distinguished from the health services system. So we're not really just talking about the interactions between the government, doctors, and patients with regard to health only, but we're also talking about an ecosystem where social determinants of health would have an impact on people as well. So we're thinking about things including economic stability, education, built environment, and community context. Those things are actually not typically in the health arena, basically have an impact on health, right? And the health system includes all of those social determinants of health. So by that definition, the health system is particularly vulnerable to shocks shocks both in the health and the non-health sectors, including, just like you all said earlier on, environmental disasters, deforestation, animal-human proximity, political unrest, things along that line, they all actually impact health. So the idea of resilience is not a new thing. And there's been a discussion of resilience in the health system for quite some time already. The first time that the concept was formalized was basically in 2005, when 196 countries signed an agreement called the International Health Regulations, which was basically an agreement for countries to report cross-border public health emergencies. And then it was discussed again in 2013 to 2016 for the Ebola outbreak. And very recently in 2021, the WHO actually launched a position paper on health systems resilience. So clearly resilience is an important and desirable attribute in the health system. But what is resilience really? There are several definitions. I'm actually going to, for lack of time, I'm actually going to discuss the one that I particularly like, which is from Haldane et al. In 2021, who basically defined resilience as capacities to prepare for, recover from, and absorb shocks while maintaining core functions and serving the ongoing and acute care needs of the communities. With that definition, and it's a mouthful actually, so you need to sort of be able to break the definition down a little bit, but that definition has a lot of implications. The first one is the fact that resilience can be planned or can be adaptive. So you might want to have a health system that would integrate systematically all active emergency preparedness planning. That health system would also need to be accompanied by the understanding and an awareness of people within the system that things may not really go as planned. And it's part of the resilient, it's part of a resilient health system to really be able to interact when things do not go as planned. And that's the adaptive resilience. And at the same time, there's also the second implication, which is the fact that the health system needs not only to increase resilience, which is the ability to respond to shocks, but also to maintain stability within the health system. So we shouldn't really put all of our resources into basically treating COVID-19 patients, but we have to reserve some of the resources to care for patients with other diseases like cancer, diabetes, or other chronic illnesses, things along that line. So ultimately, we have to maintain those two functions together. In order for us to do that, we have to do three things. We have to strengthen the health system, we have to provide universal health coverage, and we have to provide a platform or an infrastructure for their health security. And the last implication of the definition is the fact that resilience can actually be operationalized or conceptualized as an outcome, as a process, or as a capability. But regardless of how we operationalize or conceptualize the term resilience, we need to be able to understand that resilience is a desirable trait. And it's important for the government to basically think about how to include resilience in the system. So how exactly do we do that? There are several recommendations from scholars and international organizations worldwide, but the WHO in particular in 2021 basically put forth 7 different recommendations for building resilience in the health system. And they were to leverage the current response with regard to the COVID-19 pandemic. This basically refers to the fact that we need to be able to learn from what's going on with the COVID-19 pandemic and leverage that into the future when we would most likely face the next pandemic. Yeah. So the governments would also have to invest in essential public health functions, build a strong primary healthcare foundation, invest in institutionalized mechanism for society engagement, and create and promote enabling environments for research and innovation, increase domestic and global investment in health system foundations, and address pre-existing inequities, especially the disproportionate impact that the COVID-19 has on marginalized populations. And we can see that the recommendations by the WHO are actually consistent with suggestions from other academics, which I've actually put up on the screen, but I'm not going to have time to go through them all. But ultimately, if I would summarize the concept of resilience, I would say this. I would think that resilience is a combination of pre, during and post-crisis processes. And it would involve improving, expanding, and extending the infrastructure, not only in the health sector, but also in the non-health sector, to prepare for any types of crisis, with the purpose of maintaining health. It would also involve providing or creating flexibility for the health system and the community to adapt and innovate during the time of crisis. And it would involve learning from past mistakes and developing leaderships at the national and the subnational levels in order to have a stronger health system in the future. So that's my first portion of the answer. I'll get back to you in the second round. Thank you.
Thank you very much, Dr. Nopon. It's kind of very interesting when you set up already, concept about resilience, because we keep talking about resilience many times, but we never really like pinpoint in which direction that we should go. But I will come back later based on the WHO in particular, and also your summary about resilience and the concept of it, about the strategy for Thailand. Also, this can also use with the others panelists. I would like just to go to Dr. Lee next, because we see also Korean has experienced a lot of challenges and also dealing a lot of the impact from the COVID-19 in the past 2 years. Can you just share with us in a little bit about the policy that implemented by the government and the challenges that the Korean government has already dealing with, and ongoing challenges in terms of moving toward the development or already ongoing resilience development in the country? Dr. Lee, please.
Yes, thank you. First, I want to share the challenges that Korea faced during COVID-19. So like other countries, COVID-19 highlighted the limitations of the current safety net, especially wide blind spots for vulnerable workers. So we have employment insurance against unemployment risk, but its coverage is quite limited. So you can see the table on the left side. It shows the blind spots of the current employment insurance. So this employment insurance mainly targets full-time employees. So the self-employed are not eligible for this employment insurance. That's why we have a large wide blind spot, wide institutional blind spot. It's about 36% among workers. And also there is a de facto blind spot. There are some workers who are eligible but are not insured, usually temporary workers. It's about 90% among eligible workers. And for health system, we have universal health insurance, but we have a limited access to sick leave especially for vulnerable workers, and we don't have sickness benefits. So the graph on the right side, you can see the disparity in sick leave by firm size and by type of workers. So you can see workers in smaller firms and non-regular workers are less accessible to sick leave. So there is some disparity to have the period of rest when they become sick. Next slide, please. So responding to these challenges, the Korean government made several policy changes. So I want to share these policies. The first one is the government announced a roadmap to expand employment insurance to cover artists, independent contractors, and platform workers. Actually, this roadmap includes a plan to cover the self-employed. However, it is not clear yet. So to cover workers, especially including the self-employed, the important task is to establish a system to verify incomes of workers. And other policy change is we introduced unemployment assistance. So it is not a social insurance program, but a means-tested program to provide cash allowance and employment support service to low-income job seekers who are not insured under employment insurance. At the beginning of this unemployment assistance, its scale is so small, so it has been expanded again and again, but still it has relatively short support period, just 6 months. And we also implemented a pilot project to introduce sickness benefit to provide income support for sick workers, but it is still going on. So we don't have any result yet. But I think in the policy design for sickness benefit, we also need to consider the disparity to access to sickness benefit and sick leave that I mentioned in the previous slide. Thanks.
Thank you, Dr. Lee. So it's good to know that there's some adjustment in the policy trying just to help the worker, but still the challenge remain. Also, like in particular for Korean case, there's a lot of migrant worker also who in Korean, and it seems like they're also one of the vulnerable group. I'm not going to ask any question to you right now, but maybe just later if we have time to elaborate on this point in terms of the inclusive, social protection for those vulnerable group later. So I'd like to move to our next speaker, Dr. Elon, just to share the case of Indonesia, because I know we've been talking in these T20s for, already about the social protection and also the health system, not only in response to the COVID-19 impact, but also, in the post-COVID-19 responses. So can you just share a little bit in the case of Indonesia, like the policy that implemented by the government to strengthen the health and social protection in terms of response to this pandemic, and probably in the post-pandemic too? Dr. Elon, please.
Thank you, Dr. Pichaya, and allow me to share just a few slides to respond to your question. So I think so briefly before responding to the question, so just a brief flashback to Indonesia social protection system pre-pandemic. So Indonesia actually has already had all the main basic components necessary for the comprehensive and inclusive social protection system prior to the pandemic. So before the pandemic, we already divided the Indonesia social protection system already consists of two main pillars: the social assistance that mostly non-contributory schemes, consists of an array of the different programs. Perhaps the largest two is the largest three is programs on the food assistance, also on CCT, as well as on the scholarship, and some small programs on the elderly and disability. But also there's another pillar on the social security, social insurance, that mostly on the contributory schemes. We have the national health insurance. In this program, government cover the bottom 40% for their premium. But also we have the employment social protection work that include the protection toward the accidents, work accidents, the up to unemployment benefit, and also the pensions. In addition, of course, to the pension, and then the protection for the workers in the public sectors, in the formal sectors. But despite this, this kind of the comprehensive in terms of the program, the social protection programs, we acknowledge also that there are still some challenges that still make the systems actually not accessible to some of the population segments. As we know, we acknowledge, we analyze from the data. We look also we evaluate the programs. So there are some segments of the vulnerable groups that particularly the elderly, disability, children under 5, and also those that in the informal sectors, working in the informal sectors, they have challenges actually to access this social protection programs. And this also another challenge is due to the outdated targeting data. We have a significant exclusion and inclusion error that make the programs actually also leak to the, in one hand, leak to the non-targeted group, but on the other hand, it's actually not really covering the targeted group. So we launched actually the strategy document in 2018, what we call as the Toward Future Indonesia Social Comprehensive and Inclusive Social Protection Programs. And while it's already been included in the official planning document, even beyond 2024. But and while this is on progress, then pandemic hit Indonesia and hit the region, and this actually pushed the government to think to accelerate actually the reforms. So by the time when the pandemic hit Indonesia, I think government promptly act on it and respond with a very policies like expanding some of the existing programs. So majority of the program are expanded by the government in terms of particularly in terms of the coverage. Pre-pandemic, most of the program only cover like a bottom 40%, but acknowledging that the pandemic also hit the groups that above the 40%. So the government actually also cover the decile 5 and also the decile 6. So basically, during the pandemic, like a bottom 60% of the population mostly covered by the program. And government also introduced some of the new programs with the programs that not exist during the pre-pandemic, like the wage subsidy, those that so assistance to the like micro and small enterprises are among the new programs. And in addition to this social protection strengthening policies, government beyond the social protection, particularly to the nation, to improve the insurance, to improve the health sector effectiveness, government also improve the supply side, the health sector capacity in dealing with the impact of the pandemic. So government like add some improve the capacity of the primary health cares, also add some budget from the province to the districts to even to the village, making sure that they're able actually to respond to the needs related to the health that caused by the pandemic. And during this pandemic, I think government has like a spend unprecedented amount of the budget. Only on the social protection, the government like spend 1.5 GDP or close to the 10% of the government expenditures. And in 2021 and 2020, while along that the situation is normalized, still government allocated some significant portion of the social protection that is still higher than the pre-pandemic period. Let me stop there, and then perhaps I'll continue later.
Thank you very much, Pak Ilan. So I just want to circle back to Deal, because we heard a lot of challenges, not only at the regional level, but also at the country level. Not only the impact of the COVID-19, but also ongoing, other ongoing challenges like demographic transition, inadequate financing, climate change, energy security, inadequate or underdeveloped infrastructure. So when we're thinking about all of these challenges, what are the basic factors that policymakers should take into account when they're thinking about developing this comprehensive framework for the healthcare system, and also for the social protection scheme?
Dr. Pichaya for this great question. I think this is very important, particularly with COVID, as well as increasing risks of diseases and also emerging diseases from climate risks. I think it's very important that we design a comprehensive healthcare system. This is very important. And as Nopal has in his presentation, he has highlighted that basically health systems has 6 components: the service delivery, the health workforce, the health information system, access to essential medicine, financing, and governance. These are the 6 component or the pillar of a good comprehensive framework for healthcare system. So, but then these are the pillar, but to make a healthcare system very comprehensive, very let's say accessible to the vulnerables and the poor and to everyone. So there are a few things that government really needs to take into account and also prepare for the crisis that can happen anytime. And one is the adequacy of the healthcare system. They really need to make sure that these 6 components are adequate. It's timely, as one of our presenter pointed out. It's about the adaptability of the systems and also nimbleness to respond to the crisis that we can face. And affordability is very, very important component, particularly in developing countries where we have large sections of the people who are employed in the informal sectors without insurance and social protections mechanisms. We need to ensure that it is also they can also afford it and without compromising the quality. That's something that we really need to ensure the policymaker need to take into account, and also need to ensure that it's sustainable in the sense that it's not one time that you provide. You really need to provide it over a period of time. So it has to be sustainable. And in one of the presentations also I found, and I really and that's I really felt that's very, very important. We really need to have cross-border coverage, intergovernmental collaborations, because you never know how the disease spreads. So it's very important that we really need to take into account that, and above all, be prepared for the uncertainties. I think that's very, very important. We really need to prepare keep our system such that we are able to react to a situation immediately and not let it scale up. So that's something that I would like to strongly urge the government and policymaker in DMCs to take into account while designing healthcare system framework. Thank you, Dr. Pichaya.
Thanks so much, Deus. Very, very valuable input indeed. So with all this concept, I think we can just shape it up into the national level, when it's come to the policy design. I circle back again to Dr. Nopal, because we were discussing about the concept of the resilient healthcare system and social protection. So in case of Thailand, what are the strategy that the government has done, and what also the recommendation that you would suggest the government just to look into to develop or strengthen the health and the social protection system?
So allow me to share this slide one more
please.
time. I have that one last bit to go through. So thank you for that question. To be completely honest with you, I couldn't find any official documents about health system resilience by the Thai government. There was some discussion about resilience, especially in the private sector, but not by the government itself. But I don't think that particular article is particularly relevant to our discussion today. What has been discussed on, however, is the fact that the Thai health system is actually pretty strong. And I would argue that even though the Thai government perhaps at this point doesn't really have a specific strategy to build resilience, they've done a lot already towards having a resilient health system. And They've done so because they have a long history of health system strengthening. There's been a supply side expansion since the 1980s in Thailand. So currently we have at least one major hospital, one general hospital in each province in the country. The Thai government has also put a lot of efforts into making sure that there's universal health coverage. And we've had universal health coverage since 2002. The Thai government has also put forth an infrastructure for health security reforms. So there is already a health security reporting system within the Ministry of Public Health. And resilience in the Thai health system was demonstrated quite clearly during the COVID-19 pandemic with this quick establishment of the Center for COVID-19 Situation Administration and the fact that there was a really high level of community compliance with the government's regulations, which is really a distinguishing feature in the country, and especially in comparison to other countries where maybe the populations were not as compliant with the government's suggestions. This led to a low level of losses with regard to the COVID-19 pandemic compared to other countries within the same level of development. If you look at Thailand right now in terms of the global COVID-19 recovery index, we're basically at number 16 in the world. The slide is actually incorrect. I put Thailand down as number 28. That was basically last month. Currently, just if you look at the GCI dashboard today, Thailand is basically number 16. There are also other two measures that I want to highlight, and I think this would be important for the audience, perhaps maybe to go back and look at them as well, because I think they provide really concrete measures of health system resilience. The first measure is Global Health Security Index, and this is created by the Johns Hopkins University in the US in collaboration with other organizations, and they have a lot of different measures to measure the capacities of countries to detect and respond to biological threats and socioeconomic risks and political risks, etc. And Thailand in 2021 was ranked 5th out of 195 countries in the world in terms of global health security. And this is a really tangible measure of health system resilience. And it's actually an interesting read if you go through the measures that they have within the Global Health Security Index. The other measure that's also quite tangible in terms of health system resilience is the SPAR scores. SPAR is State Parties Self-Assessment Annual Reporting System, and the SPAR tool consists of basically 35 indicators, self-rated indicators that are related to the international health regulations signed in 2005, where countries are supposed to be able to detect, assess, notify, and respond public health risks and acute events of international concern to other countries in the world. And Thailand rates itself as being above the global average. So overall, I would say that Thailand, even though there's actually no formality in terms of the word resilience in any of the official documents, I think we've done a lot of work towards that. But despite these achievements, of course, Thailand still has room to grow. I would argue that we still have to continue strengthening the health system. We have to continue expanding the coverage. We have to continue improving health security. But more importantly, there has to be a paradigm shift within the government in order to prepare us better for the future pandemics or the future disasters or crises that are health-related or non-health related. And COVID-19 responses in particular have shown that health is not a well-being issue. Health is in fact a security issue because it impacts lives and deaths, it impacts the livelihoods of people all over the world, and we are all interconnected in this globalized world. And what's typically thought of as a health policy that's under the purview of the Ministry of Public Health has actually gone beyond the Ministry of Public Health. You need expertise from the Ministry of Finance, the Ministry of Education, etc. Yeah, so and we also need collaboration and civic engagement from the private sector as well as people within the community and the country themselves. So I would argue that there has to be a paradigm shift in thinking about health policies as a health specific thing or things that are specific to the Ministry of Public Health, but we need to have a whole of government and a whole of society approach to health and well-being in order for us to achieve true resilience. So thank you.
Thank you very much, Dr. Nopon. It's very interesting just to see that statistic for someone from the same country like you. It's actually quite interesting for me just to learn that. Because in terms of resilience, it looks like Thailand doing really good, but in terms of the inclusiveness, that's another thing that I think we probably have to think about it particularly when it comes to social protection. Following your comment about that this should be intergovernment coordination, not just the public health, and also like Ministry of Finance always come to be when it's come to financing using the health expenditure to develop this sector, the health sector, and also the social security sector. I'd like to move to Dr. Lee because this is a relevant question when it's come to fiscal sustainability in response to the tremendous amount of money that the government dispersed to help and also to protect the society and also to help out the society and build up the health system for this sort of pandemic and also other socio-economic challenges. So can you give me some sort of the Korean policy strategy or Korean based practices in response to this fiscal sustainability?
Yes, so financial sustainability is the keyword of the current Korean government. So we need to expand social safety net responding to the challenges I shared. But because Korea is one of the most rapidly aging countries, the financial risk of aging is expected to be quite huge in near future. So one of policy measures that the government is promoting is to strengthen pre-assessment for social policies. So the pre-assessment tests were introduced to evaluate economic and social effectiveness before introducing policies. So these tests were mainly applied to huge-scale infrastructure projects. And from 2010, it has been applied to social policies. However, it is not an easy task to evaluate the policy effects for social policies before its introduction because it's quite hard to predict the behavioral response of policy recipients. So in September this year, the government announced that it would actively use small-scale pilot programs for the pre-assessment tests for social policies. So throughout the pilot programs, more robust assessment for social policy could be expected, and it can be helpful to ensure policy effectiveness and avoid a budget waste, I hope. And another policy for financial sustainability is to make major or minor reforms on social insurance programs. So this year, we made a major reform on national health insurance premium. So the main focus was on imposing the premium on income rather than the wealth. So the government expanded the income range subject to premium payment, and the standards to be the dependence of the insured is also strengthened. So a large proportion of the elderly is the dependent of their adult children. So if they become the dependent of the insured, they don't need to pay for the insurance premium, but they can use health insurance services. But now the government lowers the income criteria on the dependents, so more older adults should pay for the premium insurance premium, even if they have incomes including pension incomes. And also for employment insurance, we increased the insurance premium, and also we restricted the repeated receipt of benefits. Actually, I think we need to make more fundamental reforms, especially for pension, because with this aging society, the most urgent reform for fiscal sustainability is the pension reform. So for the pension reform, it was decided to make a special committee to discuss and propose the structural reforms. Thanks.
Thank you very much, Dr. Lee. It's actually your comment on the fiscal reform. It's kind of aligned with one of the recommendations from our previous speaker in session 2, Dr. Upalat. And I also see the example of Korean government that doing this fiscal reform, particularly when it comes to the health expenditure. But before going into detail for that, we are sort of running out of time. I want to refer the last question to Dr. Ilan. Can you just give us maybe best practices or maybe some lesson learned from the Indonesian when it comes to fiscal sustainability?
Well, thanks for the question, and I think just let me share the just one slide, yeah, to respond to your question. And well, this is the Indonesia experience, and we hope others can also take some lessons from it. And this is the ongoing effort that the government now undertaking to develop actually more inclusive, resilience, and sustainable social protection in Indonesia. So first, we will try to establish the social and beneficiary registry for more inclusive coverage of social protection programs. We actually already been like established, developed the main beneficiary data for different social protection program in 2011, but other line ministries still have another their own database, and this all databases across different line ministries not communicate each other. So we'd like to move forward is actually like a consolidating, like building the social registry that coexists with the other beneficiary data in different line ministries and communicate, making sure that these all database are communicate each others. And the way we develop this, so we're not just going to rely on the conventional data collection through census, through survey, but also using the administrative data, the spatial data, the non-traditional collected data. Along with this, we also need to we're also moving with developing the dynamic updating for this database, including using the on-demand application and then grievance mechanisms. Second, we try to expand the social protection coverage, the social protection program coverage, and particularly to cover better the vulnerable groups, marginalized groups that so far still been mainly still excluded. Indonesia is moving toward, I think in one of the presentations of by 2050, basically Indonesia become like the age population, the aging population country. And while we have the program for the elderly, but only like very minimum number of the elderly basically covered in these programs. So we'd like to improve significantly the coverage of the program, including as well for the marginalized group, by and as well as also through introduction to some new program that is to address actually some forms of the some forms of vulnerabilities, but also consolidate some program that serve a different group or that helps us the similar purpose. Third is on the developing the adaptive social protection. Indonesia is a country in the ring of fire. We experience a lot of national eruption, natural disasters. So definitely we need this adaptive social protection. But it's not just social protection. All around the country and global actually facing the climate change. we need actually this adaptive social protection in place, including to address or to face actually the situation just that we are still facing now, the pandemic shocks or economic shocks, crisis, and things like that. Next is improving the collaboration across line ministries. I agree with Nopal. Definitely social protection is not just the issues, the matters that is need to be done by the the social ministry, social development ministry, but across different line ministries actually need to think about need to think better that this is the issue that actually they need to handle, as well as involving the community and private sectors. Yeah, so we need to partner with them as well. Next is on promoting the inclusive benefit, including the technology actually in covering better. Indonesia now moving from the ID paper base toward like the recognizing the beneficiary toward the biometric. So people in the village, they're not necessarily having the ID, so they can just show up actually in the service point with that fingerprint, with their face, and the system will recognize they're part of the beneficiaries. And last but not the least is actually promoting the sustainable social protection. In Indonesia, we're focusing firstly, of course, on the expanding the tax base. Indonesia, perhaps among the country that is still left behind on the issues of the tax, the tax base. Only 10% of the labor market that pay the tax. So definitely to sustain the social protection financing, we need the wider tax base. But also in the short term, that will take some time. But in the short and medium term, definitely we can do some. And what we are doing now is reforming the subsidy energy. So we move the subsidy energy that tend to be regressive toward the more targeted subsidy. Also on combining between the non-contributory, improving the design, and combining between the non-contributory social assistance with the contributory social insurance. Yeah. And definitely still perhaps not too related with the financing, but definitely will affect the sustainability of the social protection programs, is improving the effectiveness of the program through better design, through better quality of implementation, because if the program is effective, definitely we will use the budget better. I think I'll stop there. Thank you, Jaya.
Thank you very much, Pak Ilan. We have roughly about 6 to 5 minutes for Q&A. And I see 2 questions, one to Dr. Nopon and also one to Dr. Lee. So I just direct the first one to Dr. Nopon first, because it's saying it's from Yi, and asking that the social welfare and the social protection system in many countries were adopted for the political support and gain purpose and less fiscal sustainable consideration. How was about the case of Thailand? So any response for that one, Doctor?
Okay, that's a very difficult question.
Yeah, I agree. Yeah.
So I guess, I mean, there are many ways for me to respond to that question. I think the first one is with regard to the term fiscal sustainability, which I think Dr. Lee and Ilan discussed a little bit before. I think the term fiscal sustainability in and of itself is actually very difficult to operationalize for a lot of reasons. So first of all, when we think or try to assess fiscal sustainability, we're talking about not only the situation today, but we're also talking about the situation in the future, right? So how do we assess that? Do we assess it based on the current budget constraints, or do we assess it based on future budget constraints? If we're investing in social protection in the people now, and we strengthen the human capital now, aren't we going to get more tax-paying citizens in the future who would then contribute to the society and therefore improves fiscal sustainability in the future? So just in order to answer this particular question, I think we need to revisit the concept of fiscal sustainability first. Yeah, but that's me avoiding the question. There's also a different way for us to frame that question. In addition to understanding the concept of fiscal sustainability better, there's also the question of whether there's actually a policy process that's without politics. And my argument would be no. Like when you think about any policy process at all, when you want to get a policy, you have to define the policy problem first, then you have to formulate a policy response, then you need to aggregate and ratify the policy, then you implement the policy and you evaluate the policy. And every single point there's politics involved, right? In which case it's impossible for us to basically stay away from the politics. When we think about social protection schemes in Thailand or universal health coverage schemes in Thailand, they're both linked with political parties. And political parties basically put forth those policies because they wanted to garner more votes in the general election. So of course they're linked with those things. But I would argue that those policies, if we think of them as good policies and if they improve the lives and the livelihoods of the people, then I think the more important question is not whether or not these policies are politically motivated, because they are anyway, and any policies are politically motivated. It's for us to basically look for more funding sources and try to make sure that we reformulate policies in such a way that we take into consideration all the budget constraints today and in the future. So that would be my response to that question. Thank you.
Thank you, Dr. Nopont. I go to the next question to Dr. Lee from Daniel. So could you provide some detail on the kind of system that can verify workers' income, especially the self-employed? And also, like, Dr. Lee, remember my question that I was referring to the migrant worker earlier? If you can just address something about the social protection for the migrant worker? Or if not, that's fine too. Please.
Yeah, so currently we are making a database to collect incomes of workers together. So now each ministry, each different agency collect tax, health insurance premium, employment insurance premium, and pension premium. So the government is building an integrated database by strengthening the link between tax administration and social security administration. And for the self-employed, I totally agree that it is so hard to verify their incomes. That's why the roadmap announced by the Korean government to include the self-employed is not yet clear. But I know there is some study project by the government. So the government tried to find ways to use some credit card transactions to verify and to correct their real-time incomes of the self-employed, because credit cards are mostly used in Korea, and also try to shorten the income reporting cycle for some workers, especially for temporary workers. And for the question, Pichaya, actually I couldn't understand it yet, so.
Okay, we can discuss that offline.
Yeah. Thank you.
Yeah, since we thank you very much, Dr. Lee. Since we are running out of time, I would like just to ask each panelist for you your final word. I start with you first. Like, please spend like 30 seconds for each of you. Dil, go ahead. Your last word.
Sorry, thank you, Pichaya. The social protections is very important, particularly in Asia, given that we have very large sections of the populations in the informal sectors who are not covered by any social security program. So I strongly believe that we really need to bring informal sectors into a strong social protection mechanism.
Thanks, Dil. Pak Ilan, your last word, please.
Well, I think we need to think that that investing on social protection is not a cost. Yeah. So this is something that if we seriously invest on it, I think it will return back not just to the poor, to the vulnerable, but to the whole economy.
Thank you. That's very good point. I really like it. And maybe Dr. Lee, you next.
Yes, I totally agree with comments from discussion. It's so hard. I think it's quite important time because we need to respond to the challenges highlighted during the period of COVID-19, but still we need to consider financial sustainability. So I hope as a researcher, I want to be helpful to build more comprehensive and more effective social protection system. Yeah.
Thank you. Last but not least, Dr. Nopon.
So I just want to re-emphasize the importance of a paradigm shift. It's important for us to basically have a whole government and a whole society approach to health and well-being. And governments should really embed that idea into the policy making moving forward if we were to have a true resilience in the systems. Thank you.
Thank you very much. And I think that's wrapping up this section. I'd like to thank all the distinguished panelists for your very valuable insight. And also, like we all emphasize, it's an investment, it's not a cost, it's something that the government and also the public sector should be corroborate and mobilize the capital and the funding and the investment just to make sure that everyone doesn't get left behind. So thank you very much, everyone. And I like to finish this panel discussion. And thank you all the panelists for your participation. Thank you.
Thank you.
Thank you. So we're coming up to the last section, which is a closing section. I would like just to invite my co-organizer, Dr. Dandupon Arya Sajagon, to join me on the closing section. We have heard a lot since the beginning, a special talk from Dr. Nitaya about how to frame and how to develop this comprehensive social protection and also health system. And she focused a lot in Asia. Also, we listened to both Dr. Dodo and Dr. Siripan in terms of the health system, how to, using the technology to come up in and the digital to develop this comprehensive, as well as section 2 when it's come to the presentation from Dr. Uparat and Dr. Warwick, that not only the COVID-19 impact, and also there are also ongoing challenges, demographic transition, vulnerable group inclusiveness that we have to think about. And lastly, the final panel discussion that the building resilient health and social protection system in Asia, when we're talking about the challenges in the level of at the country level and the regional level. So I really hope that this conference giving us all the insightful knowledge, and also the audience able just to use this in your research, policy research in particular, or even in your work to really move forward for this resilient and also inclusive system. Dr. Nandupon, anything that you'd like to add?
Well, since I'm not working in the field, so it may not be my position to summarize or make more, a lot of comment about this. But anyway, I would like to share my humble thoughts a little bit. Well, we all know that the social protection system is important, of course, and even more so than ever after the pandemic. And since it is a system, we can decide it to be whatever we like it to be, of course, by taking into account of the social context and the situation. And because of all this, there is a dynamic angle on this development. And of course, we need to develop and adjust the system along with the change of the society and situation. Okay, so it is, there are so many challenges as we have discussed today, and in many level and in many angle, and let alone to make it resilient, as Dr. Nopon has mentioned, right? We need to put out all the resources that we have to make it better. But I tend to agree with Dr. Nidaya, our guest speaker, that all those challenges could be seen as the opportunities to decide and make the system better and fit into the context of the change in society, and of course to fit in country. All right, so I would like to pass on my gratitude to the ADBI team to be such a great co-host. We cannot make it, of course, without you. Thank you all of the speakers and panelists. You expand my vision a lot, and well, I learned a lot today. Thanks all the participants. Well, I hope that you take some viewpoints along with some connections today. And last but not least, I would like to give a special thanks to Dr. Nopon and Dr. Pichaya to make this event possible. Well, thank you so much. Get back to you, Pichaya.
Thank you so much, Dr. Nupon. And with on that note, I'd like just to officially closing this conference. We would like to encourage everyone that to help us develop and improve our capacity building and training program for ADBI and also our event together co-host with the Chulalongkorn University in the future. Please fill in the satisfactory evaluation form or the survey here. And also, I'd like to inform you that the material for this conference will be online, available online in ADBI website, both in English and in Russian. So you can download there. Within this week, you should be able just to download all the material. Thank you very much for all your participation, and we look forward to welcoming you in the next ADBI and also Chulalongkorn University event in the near future. Thank you and have a good day.
Thank you so much.